So I'll try to use the mouse pointer because it is lecture captured. Right, so this is a diagram that I hope you are familiar with. Just at the end of the third week intrauterine life, after flexion, okay, or the flexion has started now. So the basic, the layers of the tissues, ectoderm, the neural tube, the mesoderm in red color, and the endoderm. Right? So those are the basic, three basic tissue layers. In relation to development of the GIT, the two most important germ layers are the endoderm, which after flexion forms the endodermal tube, and the GIT is a tubular structure which is developed from that endodermal tube. Okay? And not only that, there's an important part of mesoderm contribute. So that is this part of the mesoderm. If you remember, the three parts of the mesoderm are the paraxial mesoderm, which gives rise to the somites, and then the intermediate mesoderm, which gives rise to the genitourinary system, and then the lateral plate mesoderm, which splits into the somatic and the splanchnic or the visceral mesoderm. So this visceral mesoderm, which surrounds the endodermal tube, also contribute to the formation of the GIT. Basically, the endodermal tube, please remember, it only gives rise to the mucosa of the GIT. So what is the mucosa? That is the epithelium and the lamina propria. That's it. Okay, so the endodermal tube just gives rise to the epithelial lining. Okay, so the epithelial lining has different characteristics based on the region of the GIT. For example, esophagus has got a stratified squamous epithelium with a lot of mucus glands, and that epithelium and the mucus glands are developed from the endoderm. And if you count the small intestine, the characteristic feature of the mucosa is the villi. Okay, the villi, and all these villi and the intestinal glands, they are all developed from the endoderm. Right? And when it comes to the colon, you will study, it is studied with a lot of mucus secreting cells again, and mucus secreting glands, which are developed from the epithelium. Therefore, those glands and the epithelium, they are developed from the endoderm. That's all. Okay? And all the other structures which surrounds the GIT, connective tissue and the muscle layers and the exterior covering, they are all developed from this layer, the outer layer, which is the visceral mesoderm. Is that clear? Okay? Yeah, I'll try it. Okay. It's too much? Is it all right? Right. So that's the two germ layers and the basic structures it give rise to. I'm sure you know the basic histological layers which you studied in the first semester. Okay? Layers of the GIT. So you have the mucosa, that is the epithelium and the mucus, the lamina propria, and the submucosa. Then you have the two muscle layers, which is called the muscularis propria, and then the outer covering of serosa, which is in turn lined by the peritoneum. So those are the basic layers. In addition, there are some neural tissues which is present in the submucosa. You will study this in detail in probably pathology. Okay? So in the submucosa you get some neural tissue, enteric nervous system, as well as within the two layers of the smooth muscles, you get another component of neural tissue or the enteric nervous system. So as I said, the endoderm give rise to the epithelium, which give rise to the glands, villi, and also accessory digestive organs. So anything which is derived from the epithelium, including glands, villi, and accessory digestive organs. What are the accessory digestive organs? Can you give me some examples? Liver, spleen, sorry, pancreas, not spleen, gallbladder, salivary glands. They are all developed from that endodermal tubes as diverticula or outgrowths of the endodermal tube. So that endodermal tube, they grows out to form these glands. Okay? Therefore, they will be permanently connected to the gastrointestinal system because they are developed as outpouchings or outgrowths from the endodermal tube. So they are all developed. The epithelial lining of those organs also. Again, the epithelial lining of those organs, right? Not connective tissue surrounding the organ. They are developed from the endoderm. Then the splanchnic mesoderm gives rise to most of the other structures, which includes the serosal covering, the muscles, both longitudinal, which is outside, and the circular muscle layer, which is inside. Then the submucosa, which is again connective tissue. And again, so the mesentery, which is part of the peritoneum. They are all developed from the splanchnic mesoderm. Then the last, other than those two components, the splanchnic mesoderm and endoderm, there's another important component in the embryo which give rise to the GIT, are the neural crest cells. So the neural crest cells, which detach from the neural tube, they migrate into the developing GIT. They migrate into the submucosa and between the two muscle layers. And they give rise to the submucosal plexus, and within the muscle layers, the myantric plexus. So that is by the migrating neural crest cells. And they then form, these neural crests give rise to an important part of the nervous system called enteric nervous system, or the third nervous system. Okay, you have somatic nervous system, autonomic nervous system, and now an enteric nervous system. Right? So because of GIT has its own nervous system, it can function on its own. Right? Okay. So these are the neural crest cells. You can see they detach from the neural tube, and then they migrate all over the body into the skin, and they form the dorsal root ganglia. You remember all this? And then some of these cells migrate forwards, give rise to adrenal medulla, and the cells which migrate into the developing GIT give rise to the enteric nervous system. Right. There's one more cell cluster that I want you to pay attention to, this one. You can see some of these cells, neural crest cells, which migrate and they terminate their journey. What is this? This is the dorsal aorta, developing aorta. Okay? And some of these cells terminate in front of the aorta in relation to main branches in the abdominal aorta. And they give rise to a set of ganglia, celiac ganglion, superior mesenteric ganglion, and inferior mesenteric ganglion. And these three ganglia are important in the innervation of the nervous system, as innervation of the GIT. Okay? So some of the neural crest cells, they migrate into the GIT, give rise to enteric nervous system, and others, some of the others, they terminate in front of the aorta in relation to the three main arteries of the abdomen: celiac, superior mesenteric, and inferior mesenteric, forming celiac, superior mesenteric, and inferior mesenteric ganglia or plexus. Okay? And if you take a cross section of the abdomen during early development, you can see that's the GIT, developing GI tract, the splanchnic mesoderm, you can see the splanchnic mesoderm not only covers the GIT, but it anchors the developing endodermal tube onto the posterior abdominal wall as well as to the anterior abdominal wall. Right? And this part of the splanchnic mesoderm which connects the GIT to the posterior abdominal wall is your dorsal mesentery. So during the development we call it dorsal mesentery. So it helps attach this floating GIT into the anterior and posterior abdominal wall. So the dorsal and ventral mesenteries, they are developed from splanchnic mesoderm. Now because of this, if you imagine the abdominal cavity, you can see the dorsal and ventral mesenteries divide the abdominal cavity into left half and the right half. So you have a peritoneal cavity. It's now split into two halves, left half and right half, by the dorsal and ventral mesentery. Okay. Now in the peritoneal cavity, now that's the inner lining of the peritoneal cavity and the organs which is developed from the splanchnic mesoderm, and the outer lining here which is developed from the somatic mesoderm. Now in the adult, this lining will give rise to your visceral peritoneum, this part, and the outer lining of the peritoneal cavity will give rise to your parietal peritoneum. Clinically this is important because this is visceral peritoneum which is developed from the splanchnic mesoderm is relatively painless, not pain insensitive, whereas the somatic mesoderm which gives rise to the parietal pleura is very pain sensitive. That's an important thing. Okay, so the two peritonia, but there you can see it's just a continuous layer. Although we call it developmentally they are different, it's a continuous layer, just like your parietal and visceral pleura. Okay. Right, so we have done that. The tube is anchored to the abdominal wall by the dorsal and ventral mesentery. Yeah. The next thing is, so now we have a tube formed inside the abdominal cavity, future abdominal cavity, and it is divided into three parts: the foregut, midgut and hindgut. So I'll use this slide to explain that. So that's the embryo, that's the endodermal tube. Okay, so starting from the oral cavity to the future anus, that's the endodermal tube. What is this? Anyone? You have done this? Can't hear. Which all? Intestinal duct. So this is a duct that you study, which connects the yolk sac to the middle part of the developing GIT. Okay, so it goes out through the umbilical the stalk into the amniotic cavity. So that's the vitalointestinal duct. And this is another duct you haven't studied in detail, but anyone who knows this? It's another duct which connects the lower part of the GIT into the amniotic cavity. What is that? No. That's the urachus, or also called the allantois. Okay, so that connects the lower part of the GIT into the peritoneal cavity. The importance of this was in relation to the development of the kidneys and the bladder. The bladder develops from this part of the GI, the endodermal tube here. So when the embryonic kidneys form urine, they initially drain into this part of the endodermal tube, which is called the cloaca. And from there, via this tube, the urine is passed into the amniotic cavity. So That's why this duct is there. Okay? And the remnants of this duct can be seen in the lower part of the abdomen from the symphysis pubis up to the umbilicus as a ligament, the median umbilical ligament. Okay? So that's a structure that you will see in next few practicals. Okay, so that's not relevant for the development of the GIT. So that's a GIT. And what is that? That's the ventral mesentery, attaching the GIT into the anterior abdominal wall. So that's ventral mesentery, double fold of splanchnic, or the double fold of visceral peritoneum. That's the dorsal mesentery, a double fold of visceral mesentery, visceral peritoneum, which attached to the posterior abdominal wall. So ventral and dorsal mesenteries. And this is the aorta. And these are the three components. So to understand easy, we divide the GIT into foregut, midgut, and hindgut. So foregut give rise to from mouth to the second part of the duodenum. Midgut give rise to the second part of the duodenum up to the distal transverse colon. So up there, somewhere up to the close to the splenic flexion. And the hindgut give rise to the rest of the GIT up to the anal canal, not the anus, okay, onto the anal canal. So those are the three components of the GIT developmentally: foregut, midgut, and hindgut, right? So ascending colon developed from what? Yes? Midgut. So up to the distal transverse colon is midgut. So ascending colon, cecum, appendix, they are all developed from the midgut. Okay? Right. Now let's look at the blood supply. Foregut is supplied by a celiac artery. So the foregut artery is the celiac axis. Right? So that's the celiac artery. So any structure which is developed from the foregut, which includes your esophagus, stomach, first part of the duodenum, and all the accessory organs which is coming out from the foregut, like liver and pancreas, they are all supplied by the celiac axis. Okay, so if you know that foregut artery is celiac artery, so anything which is derived from the foregut will be supplied by branches of the celiac artery. So branches we will study when you go on. Then the second midgut artery is the superior mesenteric artery. So any structure which is derived from the midgut, so up to transverse colon, the distal end of the transverse colon, is supplied by the superior mesenteric artery and its branches. And the third one is the inferior mesenteric artery, which is the artery of the hindgut, and it supplies the most distal part of the gastrointestinal system. Right. So so you know the blood supply now, okay? And that's the developing nervous system, brain and the spinal cord. And let's look at the innervation of the GIT now. Foregut is supplied by, GIT is a visceral organ, so they are supplied by the autonomic nervous system, both sympathetic and parasympathetic. The parasympathetic innervation of the foregut is by the vagus nerve. So it is coming from the brain stem. It's a cranial nerve. Okay. So the vagus nerve supplies the foregut with parasympathetic supply, and sympathetic T5 to T9 segments. Right. So from T5 to T9 segments of the spinal cord, the sympathetic nerves from these segments form the greatest splanchnic nerve, which you have seen during your dissections. Last two sessions, okay, and they appear in this splanchnic nerves. There's a big nerve coming out from the sympathetic chain. It appears on the thorax, and it goes down into pierces the diaphragm and goes into the abdominal cavity. And this greater splanchnic nerve supplies the foregut region mainly, right? And they are supplied by a plexus called the celiac plexus, okay? This is the celiac plexus. So in the plexus you get numerous nerve fibers derived from the sympathetic as well as from the vagus nerve. So the celiac plexus has sympathetic and parasympathetic both. However, it is only the sympathetic nerves which synapse there. So the cell bodies of the post-ganglionic sympathetic fibers will be located in this celiac ganglia. Now it is a little bit different from the general structural arrangement of the sympathetic system. Generally, sympathetic system, the post-ganglionic cell bodies are found where? In the sympathetic chain. So preganglionic neurons start in the spinal cord, and just after coming out of the spinal cord, it synapses with the second neuron, which is the postganglionic neuron cell body within the sympathetic chain. However, the splanchnic nerves are different. The greatest splanchnic nerve, for example, they are preganglionic nerves. They come through the chain, but they don't synapse. So they are preganglionic neurons. They comes out. So the splanchnic nerves, or the thoracic splanchnic nerves, they are preganglionic neuron, and they synapse only in the celiac ganglion, superior mesenteric and inferior mesenteric ganglion. So their postganglion neuron starts there. Is that clear? Okay. So T5 to T9 and the vagus nerve through the celiac axis supplies the foregut. Then midgut is supplied by the same way. Vagus nerve supplies the parasympathetic innervation. So it forms the contribute to the superior mesenteric plexus around the superior mesenteric artery. And then sympathetics are coming from T10 to T12 segments. Right? And that nerve is the lesser splanchnic nerve. Right? So sympathetic fibers T10 to T12 segments via lesser splanchnic nerve comes and contribute to the superior mesenteric plexus. So the superior mesenteric plexus then supplies the midgut. Then the third part, the hindgut, is innervated by the inferior mesenteric plexus, and the sympathetics are coming from T12 to L2, T12, L1, L2, and the T12 nerve is the least splanchnic nerve, and L1, L2 nerves are their lumbar, and they are splanchnic nerves, so we call lumbar splanchnic nerve. So greater splanchnic, lesser splanchnic, and least splanchnic, they are coming from the thoracic region, we call thoracic splanchnic nerves. And you already know the sacral region, S2, S3, S4 has some parasympathetic splanchnic nerves, we call they are sacral splanchnic nerves. Okay? Right. So inferior mesenteric plexus get contributions from T12 via least splanchnic and also via L1 and L2. Then the parasympathetic components, now it's not coming from vagus. The inferior mesenteric plexus gets the parasympathetic output from the S2, S3, S4, pelvic splanchnic or the sacral splanchnic nerve. So the vagus nerve therefore does not supply the hindgut. So up to the midgut, up to the distal transverse colon, the parasympathetic innervation is by the vagus nerve, but descending colon, sigmoid colon, rectum and the anal canal, that is not from the vagus. So intestinal glands or the smooth muscles, which is responsible for the peristalsis of the descending colon and downwards, they are not supplied by the vagus. Okay. So vagus only supplied up to the midgut. Okay. So that's the general innervation. So we have covered the artery supply, basic, and the nervous supply, and it is directly related to the development, foregut, midgut, hindgut. Okay? And the third one is the lymphatic drainage. It is again, there are three sets of nodes, celiac nodes, superior mesenteric nodes, and inferior mesenteric nodes in relation to the three main arteries, and they drain the three different components of the GIT. For example, liver, which is developed from the foregut, will ultimately drain into the celiac nodes. Clinically, if you get a hepatoma, you can get secondary deposits in the celiac nodes. Right? Or if you see an enlarged celiac nodes in a CT scan, then you can think of any foregut structure which can be affected. Is that clear? Okay. So these are the main groups of lymph nodes draining different parts of the GI tract. Superior mesenteric, celiac, superior mesenteric and inferior mesenteric. But please remember, there are other intermediate nodes. For example, now that's the GI, the intestine or GI tract, and that's the mesentery, and you get these blood vessels running inside the mesentery, right? So that's another thing that you have to understand. Whenever a blood vessel reaches an artery, a structure which is covered by peritoneum, they have to go through the mesenteries. There's no other way. So that's one function of the mesentery. They not only anchor the GIT onto the abdominal walls, but they transmit blood vessels, nerves and lymphatics. So if you cut a mesentery, you are cutting the blood vessels, lymphatic and nerves there. So that provide a pathway for these structures to reach the GIT, okay, from the posterior abdominal wall, because your aorta, your lymphatics, your nervous system, everything is in the posterior abdominal wall. So to come anterior, they have to pass through the two layers of the mesentery. Okay. So coming back to the lymphatics, you get, so for example, if there's a, just imagine there's a malignancy here in the foregut. So that will be first drained by the lymph tissue in the esophageal mucosa. Right? And you studied in your lymphatic, practical about different lymph aggregations associated with different systems. Mucosa associated lymphoid aggregations, remember that? MALT? Right. So that's the first group of lymphoid tissue which drains a mucosal tumor. So if there's a tumor in the, say, stomach, first the MALT, the MALT, mucosa associated lymphoid aggregations, tissue will drain that. Okay? And then after that, the lymphatics will follow the arteries, celiac artery for example here. And along that you will get multiple nodes, and they are called mesenteric nodes. They are intermediate nodes. And so the lymph will be filtered through all those nodes and finally come to the celiac axis in the foregut. Okay? For midgut, for example, in the small intestine, what is the MALT in the small intestine? Peyer's patches. So initially that tumor will be drained by the Peyer's patches. And then the small nodes going along the superior mesenteric artery, which are called the mesenteric nodes. And then finally to the superior mesenteric nodes. Okay? And the superior mesenteric node then go to the lumbar lymphatic trunk into the cisterna chyli and then can go off. Okay. So do you agree that you now know about 30% of GIT? Because you know nurses, the innervation, you know the lymphatic, basic lymphatics, you know the blood supply. Okay? So that's the basic structure. This part here, we'll talk this about the development of the anus later, the last lecture probably. So that is not developed from the endodermal tube, right? The anus is developed from the ectoderm. Right, this I'll quickly go through this one. This is not that important slide. So this is the basic pattern of GIT. You get inside in the uterus, in vitro, yes. Some of these regions develop to enormous size. For example, stomach, right? And some regions grows in length, small intestine, for example, right? And then there are many outpouchings, so diverticula. For example, salivary glands are related to the most proximal part, and they are all developed as outpouching of the endoderm, and then go on dividing to form salivary glands, and they will be connected via this duct because there are outgrowths. Liver develop again as an outpouching from the foregut, hepatobiliary system, gallbladder, right? So that's liver and the hepatobiliary system is again as an outpouching coming from the foregut. Another one is the pancreas. Pancreas develop as two buds, ventral pancreatic bud and the dorsal pancreatic bud, and then they later the two fuse. So that's another outpouching of that. Okay. So and they give rise to accessory digestive organs. And the respiratory system we discussed last few months. It's the respiratory diverticulum also coming from the foregut, right? Again, which is again endodermal. Tracheal cartilages develop from endoderm? Yes or no? No. Again, only the epithelium, remember that, right? The pseudostratified columnar ciliated epithelium, the mucous gland, that's all. The cartilages and the smooth muscles are coming from the surrounding mesoderm, that region, that's it. Okay. Yep. All right, so coming to the peritoneum and the peritoneal fold. So now we studied two different mesenteries, ventral and dorsal mesenteries of the GIT. Now, in the ventral mesentery, have you seen we have seen the GIT, when you open the abdomen, is there a connection between the intestinal loops and the anterior abdominal wall? No. When you open the abdomen, they are free there, okay? They are not attached to the anterior abdominal wall, but they are attached to the posterior abdominal. You can't just pull them out, okay? So they are attached to the posterior abdominal wall, but not to the anterior abdominal wall. Did you see anywhere in the abdominal cavity there's attachment from the GIT into the anterior abdominal wall? Anyone see? From the umbilicus. There's a small structure. There's only attachment is in relation to the liver, which you haven't seen because it is covered by the diaphragm already. Okay? So initially in the embryo, there's a direct, throughout the abdominal cavity, the GIT was attached to the anterior abdominal wall. However, most of this ventral mesentery disappears. Please remember that. The ventral mesentery disappears except in relation to the stomach and the liver. Okay, that's the first thing to remember. So there won't be any anterior structure connecting GIT to the anterior abdominal wall. Everything disappears except in relation to the stomach and the liver. Then, however, most of the dorsal mesentery persists, and that is why you can't pull out the GIT. They are all attached to the posterior abdominal wall. So dorsal mesentery basically persists. However, the position changes attachments. They are not always attached to the midline. They can be attached to the lateral, and it can be attached transversely, and the attachments might change. Okay, and those things we will study later. So let me explain the fate of the ventral and dorsal mesentery. So now in this diagram, this area is shown, right? So that's the midgut. This is your vitalointestinal duct. This is the foregut, which area giving rise to the stomach. Okay. Here is your ventral mesentery, and that's the dorsal mesentery. This is the posterior abdominal wall. The orientation clear? Okay. Ventral mesentery disappears, except in relation to the stomach. There. So there's no ventral mesentery above that and below that. Okay. So therefore, there's a lower margin to the ventral mesentery. This is the lower margin. So in the body, you should be able to see this lower margin, lowermost margin. Okay, there should be a sharp margin to the mesentery. Then the liver and the hepatobiliary system develops into the ventral mesentery like that. Right? So the liver which developed from the GIT, it grows into the ventral mesentery and it splits the ventral mesentery into two. Anterior component called the falciform ligament and a posterior component which attaches the stomach and the liver. You can call it the hepatogastric ligament because coming from liver to the stomach, hepatogastric, or it's called lesser omentum. So therefore the lesser omentum and the falciform ligaments are derived from ventral mesentery. So in the exam, if you are asked, point a pin somewhere there and ask what is the embryonic structure, ventral mesentery. Okay, it's developed from the ventral mesentery. Then similarly, dorsal mesentery splits into two by the developing spleen. So spleen develops posterior to the stomach initially. So it splits the dorsal mesentery in relation to this area, in relation to the stomach, into two components. And during that time you get the developing kidney as well, which is in the posterior abdominal wall. You need that to name these two. The gastrosplenic ligament from stomach to spleen, gastrosplenic ligament. So gastrosplenic ligament is not a ligament, it is just a peritoneum. Okay, we call it gastrosplenic ligament. And then from spleen to kidney is called the splenorenal ligament. In some books this is described as lianorenal, L-I-E-N-O, same. I think it's easy to remember splenorenal, spleen to kidney. Okay, so this part of the peritoneum, dorsal mesentery, will attach spleen to the area of the kidney. Okay, so dorsal mesentery splits into gastrosplenic and splenorenal ligament. So these are some derivatives of the ventral and dorsal mesentery. Okay, is that clear? So you need to identify these structures in Wednesday's prac. Okay, so if you stick with the basics, so what structures they are attached to, in between what structures they are found, you can easily locate them. Okay, right. Then rest of the mesentery of the GIT give rise to the mesentery of the small intestine, which is in relation to midgut, and different mesenteries of the hindgut, which later become your mesocolon, the dorsal mesentery. So the dorsal mesentery persists and they give rise to gastrosplenic, splenorenal, mesentery of the small intestine and the mesocolon. Whereas most of the ventral mesentery disappears except the falciform ligament and the lesser omentum. It's a summary. Okay? Okay, so we'll go into a little bit detail about the innovation of the GIT. So I mentioned at the beginning, the GIT has its own nervous system, the enteric nervous system. Therefore, the nervous system can function on its own to some degree, right? And it's significantly, it is autonomous structure in relation to innovation. It needs an extrinsic innovation only to fine-tune. Okay, so it can function on its own, but the extrinsic innovation can help fine-tune the function. So there's an intrinsic component and extrinsic component. The intrinsic component is the enteric nervous system, and the extrinsic system is your sympathetic and the parasympathetics coming through the celiac, superior mesenteric and inferior mesenteric plexuses. So they fine-tune. So you can do this for homework. So the structure, organization of the enteric nervous system. So this is just a cross section of the GI tract. The mucosa consists of the epithelium, lamina propria, and the submucosa here. Then this is the circular muscle layer and the longitudinal muscle layer. So in the mucosa, now what are the, let's identify the structures which need innervation. You need innervation of the mucosal glands to secrete. Okay, and that's an important structure. So you need a motor innervation for the glands to secrete. So that's a motor innervation. And then in the submucosa you get arterioles, which needs motor innervation as well to regulate the blood flow, right? Which in turn can regulate the secretions as well. And then those are the two main structures which need a motor innervation. And then you get the muscles which need motor innervation. And then of course there are sensory innervations as well, mainly in the epithelium, which can be sensitive to pH changes and mechanical stretching. Okay, so any visceral stimuli. So there can be sensory receptors in the mucosa, and there can be sensory receptors within the muscles as well for stretch. Okay, so it needs an innervation. And this is supplied by two plexus, the myenteric plexus, which is located between the two muscles, and the myenteric plexus predominantly innervate the muscles, predominantly. So they innervate the muscles, and there are interneurons. So that's the myenteric plexus. And the other plexus is submucosal plexus. They predominantly innervate the submucosal blood vessels and the glands, predominantly. That means submucosal plexus can innervate the muscles, and the myenteric plexus can also innervate the glands as well. Okay? And then sensory, so those are the motor, and then the sensory neurons from the epithelial lining feeds into the submucosal plexus as well as myenteric plexus. Just to give you an example, this is how it works. Say, when the food comes here into the lumen, it will cause stretching of the intestine, the epithelium, or the food there have chemoreceptors, can be triggered by the different chemicals in the food. And these sensory neurons will sense that and then feed back into the submucosal plexus to secrete intestinal secretions, right? And also it can feed into the myenteric plexus so that the muscles contract to propel the food. Just an example of how it functions. Okay, so that way the GIT can function on its own. When the food comes, it secretes and propels. That's all what you need. Okay, and this function is fine-tuned by the sympathetic and parasympathetic nervous system. Again, gets the input from these sensory nerves. Right? And these two systems can then feed back into the myenteric and submucosal plexus to fine-tune. Right? Increase the secretions or decrease the secretions, increase the motility or decrease the motility. Something like that. So that's how it functions, the enteric nervous system. And you will study more about this in physiology. This is CNS, sympathetic.
Yeah. So that feeds into the sensory innervation. But does the sensory innervation also feed back into the CNS, as well as the other two inherent nervous plexi?
So this is the sensory innervation. It feeds back into these two plexuses, as well as into the central nervous system. Okay. Right. And not only that, it goes into some of these neurons goes into the thalamus and the cortex as well. And when we discuss about the pain, we will discuss it. Okay, it's there. Okay. I think we discussed this in the previous slide, the same thing. Okay, just to save time, I will skip this slide. It's the same thing. So you get the three ganglions: superior mesenteric, celiac, and inferior mesenteric plexus, and their connections. Can I skip that to save time? Okay. So go through that diagram if you have any problems, we can ask during the practical. Again, I'm not going to detail this. This gives an idea about how the different spinal cords innervate the visceral organs. That we already studied heart, right? So, and this diagram gives the other innervation of the other organs as well. Roughly, and this understanding of this is important in relation to understanding the pain, just like in heart. Okay? But remember, the heart was innervated by T1 to T3, and therefore we can explain the referred pain from the heart going into the T1 and T2 dermatomes. Same thing applies to the GIT. So T5 to T9 roughly innervates the foregut, T10, 11, and probably 12, and it supplies the midgut, and then T12, L1, and L2 supply the hindgut. And this provides the basis of referred pain of GIT, right? Basically, when there's a foregut structure affected by a noxious stimulus, it causes epigastric pain, and that roughly corresponds to the T5, T6, T7, T8, those dermatomes. Which one? Okay. Now, yeah, I know. So there's always an overlap. I will say it is T5 to T9. Somebody else will say it is T6 to T8. Okay. So there can be an overlap in segments, right? The first one and the last one can always overlap. It depends on the book. Okay. Just study one and then be aware that there can be an overlap. Okay. So T5 to T9 roughly correspond to the epigastric region, that is above the umbilicus. So any pathology in the foregut, like stomach, liver, first part of the duodenum, when it is affected, you will get epigastric pain, right? On the skin over the abdominal wall. So that is because it is innervated by T5 to T9. Then midgut is predominantly innervated by T10. It can be 9, 10, and 11. Okay, predominantly 10. So small intestine, your appendix, and you all know the appendix pain initially get the periumbilical pain. That is because it is innervated by T10. Right? When you get appendix, the first time you feel pain around the periumbilical region. So that's the referred pain from that. Then lower part of the GIT, hindgut, generally, that is the pubic region. Okay, so how do you apply this in practice? Somebody comes to you with periumbilical pain, you can say probably this patient is having a problem in the midgut or origin structure. Right? You may not be correct always, right? But you can safely assume, right, in your differential diagnosis, this is probably a midgut structure. If it is epigastric pain, or this is unlikely your anal canal or sigmoid, right? It can be anything from the foregut. It can be your gallbladder, it can be your liver, it can be your stomach. Okay, so that is why you need to study this. But this is not a perfect one. Remember that. There can be alterations. Yes.
So there's different nerves because of like genetic variation, or is it
Partly maybe genetic variations, partly probably due to the research studies. Okay, and hardly the same. It can be T1 to T3, it can be C8 to T2 in the some. It can go up to T5 in some cases. Okay, it's a lot of variation. Right? You don't have to study the variations, but stick with one plant and be aware about the variation. That is important. Okay. Okay, so let's do this and take a break, small break. Small intestinal glands are developed from foregut endoderm. True or false? False. It is from the midgut, small intestine, midgut. Small intestinal glands are developed from the midgut endoderm. True. Smooth muscles of the ileum are developed from midgut endoderm. Smooth muscles, they are not, they are developed from the mesoderm. Gallbladder epithelium is developed from the mesoderm of the foregut. Gallbladder epithelium is endoderm. It's the endoderm of the foregut, not the mesoderm. Okay, but the gallbladder musculature, the connective tissue, they are from the visceral mesoderm. Entire liver is mesodermal in origin. Yes? No. Because the liver, the parenchymal tissue is developed from the endoderm. So the liver cells, the liver parenchymal cells, the cords, right, in histology, all those cells are developed from the endoderm, and then the other connective tissue is developed from the mesoderm. Okay? The glandular secretions of the sigmoid colon is under the control of the vagus nerve. Sigmoid colon is your hindgut. Hindgut is not innervated by the vagus nerve. The parasympathetic component of the hindgut is by the pelvic splanchnic, S2, S3, S4 component. Celiac plexus blockade could potentially be effective in alleviating pain signals from upper distal transverse colon. Yes? Yeah, I know. I mean, if you follow the gender plan, it is false, but it is true because of this. You can see, this is why I put this diagram into this here. You can see the superior mesenteric ganglion is here. However, the nerve fibers reach the superior mesenteric ganglion mostly through the celiac ganglion. They pass through that and then come here. Okay? So therefore, celiac axis blockade can alleviate pain in the midgut region as well. And that is the reason why I put this diagram here. Alright, take a small break.